Het is niet een hele goede al wat goed met elkaar liggen of zo.
Nee.
Niet in skills verder wel uit.
Alleen dan ja, maar die moet wel even gedaan hebben.
Dat kan doen.
Ja, maar dat is een manier voor wider. Dat moet gewoon wel even zeggen.
Ja, herhaal het wel, maar de rest niet kunnen aanvullen. Jij zei, Jamie, wat mijn naam is. Ja, dat heb ik ja, en ik heb ook een dit land.
Ja, ja.
Ik heb wel een heel
Ja, dat komt niet gaan. Dat is een ietsje voor.
dat is wel een beetje.
Ja. Zeg maar je groepen en mensen die dat ook een beetje bij elkaar nemen. Want dan worden natuurlijk echt een ding. Ja, ik voelde echt een beetje een soort van.
Je ziet dat één zeggen en dan zeggen ja, niet. Weet je wel, je zag één man zeggen de deur en dan gaan er 5 mensen achteraan rennen.
Ja, nee, en ik zeg soms is het best wel goed. Als je dan niet
ja, dit is allemaal natuurlijk wegdienen, dus ik heb er maar niet mee te maken. Nee, dat is wel niet. Nog een beetje
ik ben al deze met naam. Jawel,
voor in ieder geval weer veel. Voor mensen die niet zijn, maar voor die niet houden echt.
Oh, als je
ja, ik heb even deze. Je kan geen met deze uit. Je kan geen gezicht voelen. Maar je moet van hoe ziet het eruit. We kunnen maar helemaal niks. Ik heb niet kunnen beschrijven hoe zij eruit ziet. Ik vind het wat is niks voor. En dat maakt het natuurlijk.
See you after. Thanks for joining the session.
Wat maakt het
Nice topic. Ja, maar dat is gewoon ja. Dat vond ik. Ja. Dat heb ik niet gedaan. Maar het was gewoon. Oké. Ja. Weet je, ik was heel erg een pushen en dat ik het noemen, maar ja, maar ja. Wat zeg je? Remco, moet jij niet hier gaan staan? Zo? Of, hier loopt zo. Ja. Alleen daarna moet je daar gaan zitten.
Dat maakt niet uit.
Ja, dat is waar.
There.
Just gonna wait one more minute. Still people getting in. Okay. Thanks for being here with this session. Oh, there are still people getting in. We're almost starting. So thanks for being here, and very happy to have this session together with you on the integration of WASH, nutrition, gender transformative approaches for early childhood development. It's a topic that's very close to my heart, and I'm very happy that we have the opportunity to present at the UN Health Conference. We are co-hosting this session together with the Institute of Development Studies, Sanitation Learning Hub, the University of Melbourne, the NOZL Institute for Global Health, and Plan International. My name is Jokele Polen, and I'm the founder of Max Foundation, which is an innovative NGO working on improving child health in the most effective way. And we do that through WASH and nutrition programming. And my colleague will tell a little bit more about it. During the session, we aim to look at how integrated programming, combining WASH and nutrition, can help with early childhood outcomes. And we prepared 3 presentations. And important is that you also have the opportunity to ask questions after the presentation, so please do. And then we'll have a panel discussion, which we'd really also like to have it as a team effort. The first presentation will be a pre-recorded presentation of Alison McIntyre. She will present a research study on the frontiers of sanitation, on sanitation, hygiene, and environmental cleanliness for child development. This study was commissioned and published by the Sanitation Learning Hub, based at the Institute of Development Studies. And Jamie Myers, he is in the room, he will then provide an update how the hub has been building on this work. Alison McIntyre is not here. She's based in Australia, and also due to time difference, it's a bit difficult to do it live. So we have a pre-recording. Alison is a senior technical advisor of the University of Melbourne, NOZL Institute for Global Health, and she brings a strong understanding of WASH, gender inclusion, health systems in their application. She has both research and implementation experience. For example, she previously led the WaterAid Australia policy and programming on the intersection of WASH with human health in Asia and the Pacific region. After Alison's presentation, Jamie will present. He's the research and learning manager of the Sanitation Learning Hub, and the hub supports the sanitation and hygiene sector with action-oriented, rapid learning and research activities. So after the presentation of Jamie, you have the opportunity to ask some questions, and Jamie hopefully can answer all the questions of the research from Alison. And then the third presentation will be by Remco Geertfried.
Hi, good afternoon, everyone. I'm Alison McIntyre. I'm a Senior Technical Advisor at the Nossal Institute for Global Health. Sorry that I can't join you in person for the session this afternoon, but I've recorded this presentation to kickstart what I hope are fruitful discussions. I'm talking about...
Sorry, guys, the video is not working, so we're just gonna try this again.
Hi, good afternoon, everyone. I'm Alison McIntyre. I'm a Senior Technical Advisor at the Nossal Institute for Global Health. Sorry that I can't join you in person for the session this afternoon, but I've recorded this presentation to kickstart what I hope are fruitful discussions. I'm talking about a scoping review I did with a colleague of mine, Claire Storm, with the Sanitation and Learning Hub, focused on sanitation, hygiene, environmental cleanliness, and child development. I won't be able to touch on everything in the report in this presentation, but if you'd like to read more, it is available online on that link on the slide above, and I'm sure there are others in the room that can lead you to where you can find the publication. I just wanted to start the presentation with this quote, and as part of the scoping review, we also conducted several interviews with experts across a range of disciplines, and this was one of the quotes from the One Health specialist that we interviewed. And I'll just read it, and that is, early childhood development and nutrition are really complex outcomes. And if they are complex outcomes, they will also probably require complex interventions. And I think that's important to keep in mind as we go through this presentation and also discuss this further. I would like to present some really clear, simple ways in which WASH can be implemented to address childhood development, but it's really not that simple. But it doesn't mean that we can't do anything. So why look at this issue? And back in 2013, there was a seminal Lancet study that showed that nutrition-specific interventions wouldn't be really sufficient to address childhood stunting, and that other nutrition-sensitive interventions such as WASH would be really critical in order to support children to survive and thrive. So the WASH sector then went on to try and understand this further, and 3 randomised controlled trials were conducted that have been discussed previously in this conference, and showed that the combined WASH solutions, or simple WASH solutions at a household level across several settings in the time that the studies were conducted, showed no impact on child linear growth. And this didn't come as a deterrent to the consideration of WASH for childhood development, but really forced us as the WASH sector to reconceptualise how we think about the role that WASH plays to address complex things like nutrition, child health, and childhood development. There are examples here from the F diagrams below around that's happened. So looking at fecal oral disease transmission specifically for infants, and also considering the role that animal feces could play. And then if you look at the one from WHO, their guidelines on sanitation health, thinking more complexly about the role of WASH systems as a whole, and the role that they play in preventing fecal oral disease transmission. So what do we want to find out and what do we want to do? And it was really 3 key things. So what's emerging in the literature in terms of considerations, or what are the ongoing challenges and gaps around conceptualising WASH for child development? What's out there in terms of programming examples, what's working or what is being tried, and is it successful? And then what can the WASH, or really the sanitation and hygiene sector, do to better address child development? And how can we think about this and adapt the way that we design programs and measure their effect from here? And of course, there were lots of ways that we could have conceptualised this right up until the age of 18, and looking at things like the role of WASH in school absenteeism on child development. But we really focused on the first 1,000 days due to the critical impact that has on child development and wellbeing. And because the focus was on sanitation, hygiene and environmental cleanliness, there was a much sharper focus on looking at enteric pathogen transmission, though that wasn't exclusive, and predominantly really in rural settings. Though we know that's not the only place that you can, that WASH is important for child development. And to think about this holistically, we adapted the WHO's guidelines for sanitation and health grouping of health impacts of unsafe sanitation and considered hygiene and environmental cleanliness. And as you can see from the table on the right, that lets us consider the direct impacts from a health or disease perspective, looking at the consequences of those infections, and then really looking at some of the broader longer term and life cycle related impacts that WASH can have on early childhood development. So what were some of the emerging considerations? And one was really around what are the WASH specific needs of young children? And while I can't go into all of them in this presentation, two key ones were around geophagy, or the consumption of contaminated or soil, but if that soil is contaminated, so children often mouth objects or their hands or eat soil, particularly if they're playing on the ground, and if that soil is contaminated with human and animal feces, the impact that can have on child health and development. And then also the safe management of childhood feces and the complexities around how that can be implemented, the beliefs around it. There are beliefs that exist that they're not dangerous, or beliefs around actually disposing of child feces in toilets can have an impact on child health. So starting to unpack the complexity of how best to manage child feces, but also understand some of those beliefs and practices. Second one was around food hygiene, and absolutely the whole food system needs to be considered here, but specifically for this scoping review, we looked at point of consumption. So looking at the literature that's emerging around the role that food hygiene can play in child health and development, looking at things like the cleanliness of where food's prepared, hand hygiene during food preparation, how food's stored, making sure that utensils and cooking equipment are off floors and that there aren't animals or rodents in those settings. So many different considerations for how food is prepared, stored, reheated and consumed. Then thinking beyond the household setting, so looking at WASH in all settings, and particularly here looking at the role of WASH in healthcare facilities, one that's critical around that time of birth to minimise infections, but also to make sure that healthcare facilities are trusted and used when children are unwell, and the role that WASH can play in that. Looking at WASH in early childhood development centres, and there's very little data out around WASH in early childhood development centres, but the data that is or are available show that these conditions can be quite poor. Potties are frequently reused and not cleaned. Hand hygiene of children and broader environmental cleanliness is limited in many settings, whether they're informal or formal early childhood development centres. And also understanding that children spend parts of their life at home, but also in other settings such as workplaces, markets, etc., and what are the considerations for WASH in those settings for young children. And then moving beyond human feces, we know animals produce the most amount of feces that's present in the world, and the role that that can play in WASH-related diseases and as well as zoonotic disease, but also the considerations of not only the presence of animal feces, but with free-roaming animals, the way in which they can be mechanical vectors for human and animal feces and the roles they might play in certain pathogen life cycles. And just to say, we went further in the report to look at some of the conceptualisation around these issues, so look at baby WASH or those considerations for WASH and young children, thinking more broadly beyond basic WASH interventions at the household level to conceptualise transformative WASH, and then where that fits in the broader consideration for One Health approaches to look at the role that humans, animals and the environment play in addressing child or supporting children to survive and thrive. So how can the WASH sector adapt? And of course, to address those WASH specific needs of young children, this idea of baby WASH is becoming much more common. And while there's no clear definition, what I'm showing you on the screen are key areas that have been identified in a UNICEF publication from East and Southern Africa, where they really delved into and tried to look deeply at some of the baby WASH considerations. And you can see those on the screen there. So this is thinking about the role that WASH plays during childbirth, looking at things we mentioned before, like food hygiene and hand hygiene, separating children from contaminated soil, looking more broadly at household cleanliness, places where children play, and also supporting breastfeeding. Another way is to really think more deeply about the transmission pathways in particular settings And so as you can see from this modified F diagram, thinking in a particular context, we know WASH can have individual, or water sanitation and hygiene can have individual and compounding effects on child health and development. So understanding in the settings across the sanitation chain, or more broadly at water systems and hygiene practices, what are the key health-related concerns or prevalent pathogens in a given context? Where is some of this transmission occurring, and where to best prioritise efforts and what they specifically are? But it's not just infrastructure to look at. You need to understand local contexts and social norms. What are practices across these transmission pathways and the behaviours associated with them? And then really, working with the health sector to understand what some of those key issues are, the role that WASH plays, and designing and targeting interventions to address those. And as I said, looking at WASH in other settings, and there is now several guidance out there from WHO and UNICEF about how to address WASH in healthcare facilities, I'm sure of which some will be or has been discussed at the conference so far. There are standards out there from different countries looking at WASH in early childhood development centres, but there is a lot more work to really understand what are the specific needs, recommendations and requirements, particularly in formal and informal settings, and then considering outside these areas as well. So looking at where children might play outside the household setting, but also formal and informal workplaces where they may spend time, and the WASH-related considerations there. And then, of course, how is this governed? What does stewardship look like to tackle this in these complex ways? And there has been some work done by WaterAid and Action Against Hunger and others trying to unpack and understand the best ways for policy, financing, accountability and governance to operate to support coordination and integration to address WASH within nutrition, but also more broadly in child development programming. And there are considerations on the screen there that is required. So making sure policies are in place and that these policies are actually financed, that the appropriate coordination mechanisms exist, and that accountability is put in place, that programs are monitored and adapted as needed. And this is not just at a national level, but also considering what needs to be put in place at subnational and local levels for this to occur. Of course, we weren't able to cover everything, and there are still some areas that are sparse in the literature, and that's really around urban WASH and child development and the specific considerations, particularly in large urban slum areas, for example. And despite all the work that's been done around gender rights and inclusion in WASH programs, when you really look at the intersection with child development or nutrition programs, this isn't as strong. So considering specific gender rights and inclusion approaches to address integrated WASH, nutrition, health and child development programs. A lot of what we found was focused on, I guess, the latter part of the first 1,000 days, and less so on considerations during the gestational period, or the first part of those 1,000 days during pregnancy, and the specific considerations then. And then also starting to think more broadly around issues such as climate change and antimicrobial resistance and the potential threat that might place on WASH and child development. So overall, there was a series of considerations that WASH practitioners can consider moving forward. And I think, again, there's another quote from the One Health specialist, but that is embrace the messiness and complexity of real life and avoid reductionism. So I think we really do have to let go of that idea that there are very simple WASH solutions that will work in all settings. Of course, they're important and they need to be done, but to really comprehensively support children to survive and thrive, it is likely to be more complex than that in many settings. And so first recommendation was really to underpin all those programs with gender, inclusion and rights approaches. So to draw on what's been learnt from WASH programs in general and really take that learning, those approaches and understanding into designing integrated programming. And you'll hear more about that across the session. You really need to understand the local context. So what might work in one setting may not work in another. You need to understand the geography, the social norms, the behaviours, available infrastructure, etc. I think we can all hopefully now agree that the traditional wash package, while important, as I said, needs to be expanded. So not just the presence of household water treatment, and that there is water available and a toilet or an improved toilet and hand hygiene at critical times is unlikely sufficient to really support child development in some settings. And that means we need to think more broadly to look not just at the household level, but area-wide and systems focus for WASH implementation. And not just, as I said, look at community settings, but looking at healthcare facilities, early childhood development centres, and formal and informal workplaces. Really looking at trying to understand that transmission pathways, and this ties with local context, is to use health data to inform WASH programming. So what priorities there are, specific WASH interventions that are best for that setting. And often that data is available at local healthcare facilities, in subnational government offices, or at various other health data platforms where you can try and understand what those specific needs are in some settings. And to do that, you'll need to coordinate and integrate with the health sector, but also more broadly nutrition, food system sectors, early childhood development sector, and education programs. And looking at the quote here from the behaviour change specialist is, yes, we are taking these steps to expand what fits into the envelope of WASH, and that's a net positive, but that also means we need to look at complex adaptive behaviour change strategies. So taking very simple behaviours or just focusing on hand washing, particularly if you're thinking at things like baby wash, there are lots of other behaviour change considerations that we need to take on board and try and understand how to best implement, and the long-term nature in which these behaviour change strategies need to be designed and implemented. And of course, there's still a lot more to learn. So to continue to conduct basic research to understand really the role of WASH and specific components of WASH in child development, and most importantly, focus on implementation research and understand what might work in which settings and make sure that's communicated. So thank you. Yeah, I hope the rest of the session goes well.
So thank you, Alison, who I'm sure is asleep somewhere in Australia, given the time difference. So my name is Jamie Myers, and I work at the Sanitation Learning Hub, who commissioned this report. And Alison kind of stole my first slide with information and where the report can be found. But just to add that it's available in English, French, and Portuguese, and that if that link is too long, just email us as well, and we can send it to you along with other relevant information. Before I wanted to start, I just wanted to say that I'm presenting on behalf of a colleague, Ruhil Iyer, who's very much leading the work on this at the Sanitation Learning Hub, but unfortunately was unable to get a visa, so is not here. I will answer questions. I will attempt to answer the questions with both from both Alison's presentation and the brief presentation I'm about to give. However, if there are any questions I'm struggling with, I will write them down and we can follow up and get those answers to you. But I will do my best. Okay, so building on the recommendations we've just heard outlined by Alison, the Sanitation Learning Hub is a participatory action research project are really interested in collaborating with implementers to support learning and research around the how. So how to embrace the complexity and messiness in the real world. So these are some of the questions we're hoping to be working on. So how are new and adapted strategies that are expanding the traditional WASH package being implemented? How are they designed? Who's involved? We know it needs to be a collaborative process. So who are the actors who need to be involved in a particular setting? How are the solutions very much been grounded in the local context? And how are we building on local knowledge, aspiration, leadership, systems, and needs? What platforms have been established that support coordination effectively with relevant stakeholders and the different stakeholders who operate at different levels within a national system? How are these strategies monitored, both in terms of outcomes and impacts? And do these vary in different, because these do vary in different sectors? And where are we seeing successes, and how can we learn from experiences to date and across different geographies? And just to say, we're currently working with UNICEF in Mozambique to answer some of these questions, especially around the development of integrated wash and nutrition models and the roles and responsibilities of different actors at different administrative levels, and the limitations and challenges and barriers faced, as well as the enablers of doing this non-siloed, the practicalities of doing this non-siloed development programming. So as part of this work in Mozambique, my colleague, not me, my colleague Ruhil Aya has been delving into the literature, both grey and academic, on interventions that are expanding this, the traditional wash envelope, as Alison put it. And there are a range of different ways that this is being done. So there's the Samnut project in Kitui County in Kenya, and I won't go into detail about this one because we have Emma, who's going to be joining our panel from the Ministry of Health in Kenya and has been involved in that. But it was a CLTS intervention which included other aspects focused on child feces management and promoting infant feeding practices, amongst other things, but I'll leave it up to Emma to provide more details on that. There's examples of baby wash programming, for example, one in Nigeria with ASF, which was led by ASF, which was a collaboration between WASH, nutrition, primary health care stakeholders with local leaders and communities, and included the provision of hand washing equipment and complementary feeding materials, as well as child wash and nutritional training, and in areas where lots of the target beneficiaries were, they also had CLTS and bore wells constructed. We have the project in Mozambique where we're doing the work, which has involved multi-sectorial coordination meetings at different levels, development of district sanitation plans, and social behavior change communications, covering both nutrition, hygiene, and sanitation. And then we have the healthy village approach in Bangladesh, which we're going to be hearing more about from Remco after this presentation. But just to say that there isn't really a standardized way that the envelope is being expanded, and it's being done in different ways and by different organizations with different partners in different contexts, which I think is probably the right way to go. However, there are some common challenges and lessons learned from these programs. And sitting in this morning's session, it seems that these are similar challenges faced within the WASH sector without expanding the performance envelope. Sorry, the WASH envelope. So there's a lack of clarity around roles and responsibilities and ownership when we're working cross-sectorially. There's a need for better coordination across multiple organizations and multiple specialists at multiple levels. These programs are similar to WASH programs, but they're often reliant on unsupported and underpaid staff and volunteers. There's very much a need to strengthen capacity of local stakeholders to lead and actively participate in these interventions. Lots of these interventions took place during the COVID pandemic, which had additional complexities and challenges. So I don't think any of these are particularly unique. Well, they're things that we also find in our general WASH programs. And then finally, the focus of this session is also we're trying to focus it on gender and what gender transformative programming looks like. Most of these focus on primary caregivers, which are predominantly women. And so we need to consider how these interventions are not just kind of gender neutral, but moving towards gender responsive and gender transformative. That's it from me. There's some time for questions.
Yes, questions. I have a mic, so I can also hand out the mic, but I think the room is small enough. Anybody? Think it's all clear?
Yeah, please go ahead. I'm not sure I'd claim we're doing anything in particular. I think the point I was trying to make there is that it's kind of lesson learned is that lots of are these I haven't seen evidence that these programs are moving towards gender transformation. So are they challenging gender roles, or are they ingrained? It's easy to work with mothers because they're the primary caregivers, and so we assume that they're going to be they're the ones who do all the childcare without. So are there ways by which we can better engage men and boys in these programs and do a better job so we're not ingraining pre-existing gender norms into the programs which we're running? We have a question over there. Their lessons learned from some from those case studies and also broader literature. Sorry if I didn't make that clear. I wanted to give those examples just to kind of highlight the differences in how it's being done in different areas, while these challenges and lessons learned are from the program documents which were reviewed as part of this study, but also from a broader range of literature. Yes, so they're donor-funded programs. So when donors no longer operate in that particular area on that particular topic, sustainability is challenged. Do any of these surprise anyone? I think they're all quite similar challenges when we're working within our sector. And we talk about cross-sectorial with water, sanitation, and hygiene. This is just adding an additional group of people which I think Alison explained we should be working with if we're really going to try to achieve those child development outcomes we're hoping for. Yeah, it's a risk. Mm. Yeah, I agree. Okay, well, it's not the end of the session, so you're in luck. I'm sorry, I'm a very glass half empty person. No, but I'm about to pass on to a very glass half full person, so you can lift your spirits back up. No, no, but I wanted to just demonstrate that there are challenges in working in this way, and there are projects which are working through those challenges, but acknowledging that they exist and not pretending that everything is going to be smooth sailing is important.
Any more questions? Because otherwise,
Mike?
yes. Oh, can you maybe also say your name? It's also nice to know who you are.
I mean, I think everybody needs to know after a few there was a huge impact. How we look at the point practices have almost put to a halt. It's difficult to say whether or not the halt was partly due to COVID because the last went after the death. But I think the question that's been in our head over the last couple of years is like, what is it that is the bottom? Because certainly, you know, the publications that we put out or water agents put out, and what they're saying here, it's important. The question is, what is it that we do? What is the real problem? What prevents us from being able to work together and achieve the results in a collaborative way? Are these the problem? Is it partly our donors, not in the sense that we're reliant on support, but because they're also trying? I think those are some of the things that we're coming around to think about. You know, nutrition is pushing for system strengthening. Wash is pushing for system strengthening. But are we pushing for system strengthening together? If we want to make large scale impact, we need to be. And I think, yeah, I mean, not posing any questions, but maybe I'm not posing any questions that I have asked you, but maybe as thought people keep able kind of addressing questions in terms of how to better go up. So far, everything I've seen is you know, we could do rather than kind of.
I think this is also a nice one to take into the panel we have afterwards, but thanks, it's very useful input. Yeah, so
There's one more.
yeah, well, yeah, and just last question because we have to, yeah. Can you say your name, please?
Yeah.
Okay,
I
thank
agree.
you. Very good. I think this is also a nice bridge for the next presentation, who's my colleague, Remco Giervliet. He will present about the results of the Healthy Village in Bangladesh. Remco is the data and monitoring specialist at Max Foundation, and he's been digging into a lot of data, over more than 500,000 data measurements of child measurements. So up to you.
Thank you very much. I'm just going to do my presentation standing because I always get very excited when I talk about the impact and the data that we've collected as an organization. So at least now I can dance around it a little more. So my name is Remco. My official title is the Data and Monitoring Specialist for Max Foundation. Unofficially, my title is just nerd, because you know, when we were asked at last year's Christmas party what brought us the most happiness in life, my answer was a well-formatted Excel file. So that's the kind of person I am, but it's not what I'm talking about here today. I'm talking about the Healthy Village approach. So first I will explain a little bit about what the approach is, and I think I will be touching upon some of the points that have already been made as well in terms of how do you really integrate WASH, nutrition, and other elements together. Secondly, I'll be talking about the data we've collected and the impact that we've seen with the approach. And then last, I will look to the future and what the results that we internally have, sort of what they would mean for integrated approaches in general. So the Healthy Village approach integrates three key elements, namely WASH, food and nutrition security and care, with the single goal of improving child health. And I think that is really the key issue. It's an approach that starts with child health and then works its way backwards to say which elements do we need to effectively improve child health. And that is also the key, how we get different people to come together, different sectors to come together. because we say it's not about WASH, it's not about nutrition, it's about child health. And what can you contribute? What can you bring to the table from your experience, from your expertise to improve child health? And with these three pillars, they're supported by being gender transformative and climate resilient elements in there as well. They sort of work across these three different elements because they touch upon all three at the same time. The approach was initially developed by Max Foundation in 2016 by my dear colleague and our country director in Bangladesh, Riyadh. Purely based sort of on more theoretical insights, again, working its way backwards, saying we want to improve child health. Which elements do we need? What is the literature telling us that we need to integrate? We piloted at a small scale in 2016 and 17. And since 2018, we've scaled up the approach and reached over 1.2 million people in Bangladesh so far. And what is unique about the Healthy Village approach is not only that these three different elements are really integrated, we're really breaking down these silos again by focusing people on child health, but it's that we work with three different stakeholders. And the first of which is communities. And that also ties into the last point that was just made. It's about communities. You have to work with households in order to work with a community, but you need to work at the community level. The community together needs to make a change in order to become a healthy village. And we raise awareness in communities, but we go much further than that. Because oftentimes the knowledge gap isn't the most important thing. People know that they need to wash their hands, they know that they should use latrines and things like that, but in practice they don't. So it's about changing their real behavior, and it's about creating demand in communities. Because we know that we've really succeeded in creating awareness when people are willing to give up their money and their time in order to build a latrine. That's when you know you're having impact. You're willing to give up something today to buy a better health for their children, to invest in a better health for their children. And then we work with local government and entrepreneurs to meet this demand effectively and efficiently. So again, it's from the households and from the communities creating demand and then meeting that effectively through the private sector and through local government. And we don't only work with these three stakeholders in isolation, we also work at the system strengthening, to work with governments to set clear standards, to make clear rules and regulations for these wash businesses. What does a latrine need to be like? What are the requirements you need in order to be an entrepreneur selling healthier products and services to households? So it's really, again, bringing these three different actors together, working to change the system, to strengthen the system, which also helps, again, the sustainability of the program. We just spoke about, we need external funding, and then when it stops, what happens? Well, if you have these entrepreneurs that gain their income from selling healthier products and services to people, they have an incentive, even after we leave as Max Foundation, they have an incentive to keep raising awareness, to keep driving demand in communities, because in the end, that's how they derive their income. It drives their own bottom line. So you create the sustainability within the program through entrepreneurs and through the local government. And as an organization, we've worked with the government of Bangladesh to define 18 indicators that capture something about the output level. The outcome level. So what is changing in these villages over time through the Healthy Village approach. And you see a few examples of them here on the slide. We track these 18 Healthy Village indicators on a quarterly level in all 1,600 villages where we work. And once a village reaches 90% on these indicators, we share that data with the local government, who then perform a check. And if they actually reach that 90%, they get a big plaque in the office, as you can see here. And there's a big celebration, again, because it's a community level effort. One single household cannot become a healthy village. You need each and every household in the community to contribute and to work together in order to create the healthiest environment they can for their children. And then we come a little bit more into my wheelhouse, the data we've collected to see what the result has been of our approach. And we've collected an absolutely unique data set. We've collected over 500,000 height and weight measurements of over 75,000 children in the areas where we work. That means that virtually every child in the area has been measured at least once, and that most children have been measured several times throughout the first 5 years of their life. So we don't only see the average stunting rate in communities coming down, we can see for individual children how their probability of stunting is changing quarter to quarter as they're moving through this Healthy Village process. And it makes our data incredibly powerful because it is all observational. We do not have a proper control group to compare ourselves against, but we can control for the individual child within our analysis, which makes it, again, incredibly, incredibly powerful. And the data we collect doesn't just sort of flow to me and in these nice graphs that I will show you in a minute, but it's also shared directly with local leaders, local governments, and the entrepreneurs we work with. Again, it's about empowering them. So we have developed a Healthy Village Tracker, a dashboard that you can see on the slide here as well. And they can see how these 18 Healthy Village indicators are changing over time within their community. But they can also compare their own community to surrounding communities. So they can see where they're falling behind or where they might be more advanced in their neighboring communities. Because as I said, we work in 1,600 villages, and we cannot, as an NGO, track each and every village every quarter to see where we need to put more emphasis in organization. But these local leaders and these local entrepreneurs, they can do it. And they can tell us, we need to focus more on this indicator. We need to focus more on hand washing, because all the communities around us are reaching 90% coverage, and we're only at 70. So we need to focus more on this. How can we get to also be at 90% like all our neighboring communities? And again, that's by unleashing their power of these local governments and these local entrepreneurs. And even more importantly, we share this data with the communities where you work. All our data collection is participatory, which means that the community comes together and sits together to discuss the data that they're collecting. Because the important thing about stunting or child health in general is that we can find in our statistical analysis that some intervention has causes a great improvement in the health of children. But for an individual parent, that doesn't mean much. Your child is either stunted or it's not. And for many children, their child was stunted before and will still be stunted. And for some parents, their child was never stunted. So what does it matter that you did this Healthy Village approach? Well, it matters if you're doing it together. Because if you're sitting together with 50 children who are being measured each and every quarter, you see that at the beginning, maybe 30 of them were stunted, but at the end, you see that only 15 of them are stunted. So even though your child may have never been stunted to begin with, you can see that the community level stunting rate has changed. Again, a really, really important trigger for behavior change. It's not just about what your child is experiencing, it's about what your community is doing. And secondly, it is about also putting these parents together. Again, it's not about working with households, it's about working with communities. We link parents of stunted children together with parents of non-stunted children to learn from each other. Because there is so much implicit knowledge in these communities, things that work, little tricks that they figured out over the years of how to remind themselves how to wash their hands, for instance. And we as an NGO can come in and with the best insights from behavioral economics, tell them tips and tricks of how to wash their hands at all critical times. But if someone in their community has already figured out how to do it, they've devised some little system that helps them, that's much more likely to work for everyone in their community. So we work by linking these parents together, by having people share knowledge and share experiences to, again, get the community together to learn from everyone else. Because we can say all the things we want to say, but it's never going to be as trusted and as good as receiving information from your neighbors. But we do use the data, of course, and we create little graphs like this, which show the dramatic impact we've seen in the stunting rate. We start on the right here, in 2018, at the end of 2018, with a stunting rate of 51%. And at the end, the stunting rate is halved to 25%. You see this dramatic decline in just 3.5 years throughout the program. And when we compare this to the average stunting rate decline in Bangladesh over the past decades, during this period, we would have expected the stunting rate to come down by about 5 percentage points, which means that in these areas, the stunting rate has gone down 5 times faster than the national average in a good year. And we all know that this period, 2020, 2021, covers COVID-19 as well. And it's likely that the average stunting rate in Bangladesh as a whole has actually gone up, making this decline of, again, from 51 to 25% all the more significant. And one of the questions you might have is, okay, the stunting decline looks amazing, but what does it mean for poorer households? Because you're working with entrepreneurs, so are you excluding poorer households? Or, with the peer-to-peer learning, are you excluding socially excluded households? Well, we can actually dig into that in our data, and we see that it does not matter, or any of the characteristics we can look at, the stunting rate about halves for all of the children. So the richer households and the poorer households all see the stunting rate decline by about 50% over this period. And when we dig even further into the data to see with these 18 healthy village indicators, what actually drives the stunting rate down, we see that the most important effects come from having access to safe sanitation, having access to hand washing devices, and having a clean area for your children to play in. And to a slightly smaller extent, we also see an effect from essential nutrition actions, but these are only relevant for children who are already malnourished. So it's sort of a subgroup, and it's a little hard to take that into account fully in our analysis. And you see that here in the graph, we're at the horizontal axis. As we move from this side to that side, the average healthy village score improves from about 40% here to 100% there. So again, this is the average of those 18 healthy village indicators. And as we move from the top to the bottom, the stunting rate comes down. And you see very clearly with this orange line that the stunting rate comes down dramatically as villages become healthier, as they are scoring higher on these indicators. And the second thing, when we dig even further into the data, is that we see, especially for the WASH indicators, is that community level access is more important than individual level access to WASH, which makes sense if you think about it, because when I use a latrine, it doesn't really benefit my own health all that much, but it protects all of you and it protects my community from coming into contact with my feces and my bacteria, therefore improving all of your health. And these positive spillovers are very, very strong in WASH. And you see that with this curve becoming flatter over time, because these spillovers become smaller and smaller as more people are implementing the healthy behaviors that we recommend. And there's a lot more I could say about this topic. There really is an incredible wealth of data that we've collected, and this is just the tip of the iceberg. And I can talk about this for hours, and I really have talked about this for hours. So if you're interested, please come find me, and I will happily, for the next 3 days, just talk you through everything. But maybe the most important thing here to note is that all of the data we've collected, we've anonymized it and posted it on our GitHub page as open data. So each and any one of you can go online, download the data, and recreate any of the graphs that I've shown you here today. You can do that on your systems. You can run your own analysis to see and understand what works in reducing the stunting rates for these children. And we really do encourage you to try to play around with our data, to integrate into your own programs. And if you do find something interesting, to share it with us. Because again, for us, the thing that matters is to improve the health of children. And if you find something that can help us get there, we will put it into our programs. Which brings me to my final 2 slides about sort of the future of what does this mean for integrated approaches. Well, the first project I would like to highlight is Healthy Village Ethiopia, a new program we've started together with Plan International to move the Healthy Village approach from rural Bangladesh, where it was started, to rural Ethiopia as well. The goal of the program is still the same, improving child health. But the way to get there is obviously quite different between those 2 different countries. And I would just like to highlight 4 of those differences. First is that we've set up a cross-country learning platform. Because as I said, in Bangladesh, the approach was built on these sort of theoretical insights because there wasn't much evidence from the practice yet. But now that we've successfully done it in Bangladesh, we've invited our Bangladeshi colleagues to explain to our Ethiopian colleagues how you set up a healthy village approach. What does it actually mean to break these silos? How do you actually implement this? But more importantly, what does it mean to be in a healthy village? How does it feel like to be in a healthy village? And to really inspire them to get this approach off the ground much faster in Ethiopia. And for me, it's very interesting as well, or for us, I should say, in the Netherlands, because it makes us aware of what the core of healthy village is that doesn't change between contexts, and what the context-specific parts are that need to change from place to place. Secondly, we've put a stronger emphasis on food and nutrition security, because unfortunately, as we all know, the situation in the Horn of Africa is quite dire at the moment, made even worse by the war in Ukraine. So there's a much larger focus on there. And secondly, there's also a bigger focus on being gender transformative. And that's why we're very excited about our partnership with Plan International, because they have much more experience in that place than we do as Max Foundation. Third, there's a stronger emphasis on government engagement. As I said, in Bangladesh, we work with local governments and also on system strengthening. But in Ethiopia, we've actually seconded 2 of our staff members to national level ministries to ensure that whenever there's a national debate in Ethiopia to understand, what does water do for child health? How can we improve our sanitation services for child health? That there's someone in the room saying, the question doesn't even make sense. If you want to improve child health, we have to look at all these different sectors together. And why are we only in a room here with WASH experts talking about child health? Let's get our nutrition colleagues in. Let's get our healthcare colleagues in, because we need to think together and we need to put all these different frameworks that we have, these different experiences and expertise together to really improve child health. And last, we've created more space for innovation, for learning, and for generating evidence. Because as I said, this evidence is amazing, but it's still early days. It's one NGO implementing one program in one context. So we're really excited to learn as well in Ethiopia what learns and how, or what works, and what we can learn from the approach going forward. Which brings me to my last slide. So what is our ambition? Well, it's very clear. It's about improving the health of many, many, many more children in the world. That's the goal of Max Foundation. And we want to do that in 3 different ways. One is by having others adopt integrated approaches. And again, whether that's the Healthy Village approach doesn't matter to us. It's about improving child health. So if you are starting to think more in an integrated way, start working in integrated ways in your own programs, that's a win for us. We don't need any of the credit. We're just happy that more children are getting a healthy start in life. Secondly, it's about adapting the approach to different contexts. As I said, it was started in rural Bangladesh, rolled out now in rural Ethiopia. We're starting in urban areas in Bangladesh, but there's still many different places and contexts that we haven't touched yet. And we really need to understand what works in these different contexts and how we need to adapt the approach to different places and times. And lastly, and most exciting for me, it's about growing the evidence base. Still too often there's research being done and being published, but it doesn't get implemented by practitioners. And the other way around, practitioners do these amazing case studies or have these learnings from implementation, but they only share them internally and do not share them with the sector. And if we really want to improve as a sector, if we really want to put the impact we're having ahead of how we do it and about our own and in front of our own egos, we need to start sharing our knowledge, our learnings much more intentionally with each other to really grow the evidence base, to ensure that if we make a mistake, that is absolutely fine, as long as others can learn from it and we can prevent others from making the same mistake. Because together we can really make sure that every child has a healthy start in life, that every child grows up in a healthy village. Thank you. And yeah, we have 2 little videos because, it's great that, I'm explaining this to you, but it obviously is in the end about the communities we work with. So we have just a few short videos to, show you not only what the approach means for, for the people themselves, because that's what it's in the end all about. And so please enjoy a little clip from Ethiopia.
የለንም ማለት ነው። በመጋዞ ነው የምናድር። መጋዞ አሁን ሰው በመሬት ሲያጋዛን ያችን አርሰን በጉልበታችን ሰርተን የምንቀርስ ማለት ነው። የለም ስለሌለ እርሻም የለም ምንም የለም ስለሌለ ያው ፍራፍሬ ነገር አይበሉም። አግኝተው ያውቁም ማለት ነው። አላስመጥኳቸውም። ከገበያማ ሰው ይገዛል ምናምን ይላል። አይበሉም። ገዝቻላቸውም አላውቅም። የት ይገኛል መግዣ? አሁን አታክልት ጓሮ የማልማት ቢለማ ለልጆች የሚቀምሱት ነገር የተሻለ ነገር ባገኝ ደስ ይለኛል። እኔም ማለት ነው ከሰው ተገዝቶ ተገበያ ተዛተም ጓሮ ለምቶ ምን ብሎ ቀርቦት አለ ያው ዘር ምንም ተተገኘ ጉልበቴ ለፍቼ አልምቼ ምን ብዬ ለልጆች ቢመገቡ ደስ ይለኛል። ዋናው መገኘቱ ነው ደስ የሚል ማለት ነው። ያው እኔ የጤና ኤክስቴንሽን ባለሙያ ሆኜ ስሰራ በቀበሌው 1722 ወይም 1722 የሚሆን አባወራ አለን። ከዚህ ውስጥ 1001 የሚሆነው ከ5 ዓመት በታች ህፃናት ናቸው። በአጠቃላይ ስራ ስንሰራ ግን እናቶች ጤና ላይ ህፃናት ጤና አገልግሎት በአጠቃላይ 18 የሚደርሱ ፓኬጆች አሉ። እነሱን በማስተግበር ረገድ የሃይጂን ሳኒቴሽን ስራዎቻችንን ሳናቋርጥ እንሰራለን። በቀበሌው ተቀይሮ እንዳየው የምፈልገው ነገር ያው ለቤት በመሄድ ግንዛቤ እንፈጥራለን። ግን ተግባራዊ ወይም ወደ ተግባራዊ መግባቱ ነገር ያን ያህል ስለሆነ ያሉ ችግሮች ተቀርፈው የውሃ ችግር ያልኩሽ ሽንት ቤት ሰርቶ የመጠቀሙ ሌላም እንደዚህ ግንዛቤዎችን በመያዝ ሰው ማምረትም መስራትም መኖርም የሚችለው ጤናማ ሲሆን ስለሆነ ለምሳሌ አሁን የአንድ ልጅ እናት ነኝ ብዬሻለሁ። የኔ ልጅ የቀበሌው ልጅም መስሏል ወይም የኔ ልጅ እንደሆነ ሁሉ የቀበሌው ልጅ ወይም ህፃናት ሁሉ እንዲሆኑ ፈልጋለሁ። የኔ ልጅ አሁን ሆኖ እንዲሆን የሚፈልገው ስርዓተ ምግብን አሟልቼ መግቤው ንጹህ ኢንቫይሮንመንት ተፈጥሮለት በቃ ፍሪ ሆኖ አድጎ ፈለገው ቦታ ላይ እንዲደርስ ነው የምመኝ። ለኔ ልጅ እንደምመኘው ሁሉ ደግሞ በየቀበሌው ህፃናትም ልክ እንደዚያ እንዳልኩሽ ሆነው አድገው የፈለጉት ቦታ ላይ እንዲደርሱ ንጹህ ኢንቫይሮንመንት ያስፈልጋል። ይሄው አጥርት ተቀርፎም ማምረት የምንችለውን ነገር አምርተን ስርዓተ ምግብን አሻሽለን መግበን ልጆቻችን ጤናማ ሆነው ማየት ነው የኔ ህልም።
Participants. One of the development partners currently supporting the government effort is the Healthy Village program led by the consortium of Manx Foundation and Plan International. It's a unique flagship that is being implemented in Amhara region. Dear participants, the Healthy Village program is an innovative 5-year 2020 to 2025 integrated multi-sectoral approach to tackling stunting and working hand in hand with the government of Ethiopia from national to local level. The Healthy Village program aims to reduce stunting and water and fecal-borne disease in a sustainable manner. It contributes to the attainment of the ambitious Sekota Declaration expansion phase targets through learning, evidence, and engagement. Last but not least, the implementation of Healthy Village program is led by the regional government with a strong commitment. We are looking forward to document the lessons from Healthy Village program implementation and share to other parts of the country using the Sekota Declaration expansion phase as a platform. Similar initiatives are also welcomed by the government of Ethiopia to ensure optimal wise service access to our citizens and speed up the prosperity of the country. I thank you.
Okay, we have 5 minutes for some questions before we go into the panel. And I'm curious if there are some questions for Remco. I see 2 hands. Can you also state your name, please?
Hi, I'm Bethany Crusoe. I'm from Emory. I have a question for you. Kind of piggybacks on what Mikhail was raising earlier about, you mentioned gender transformation, so I wanted to ask specifically about what you all were doing related to gender transformation and specifically some sub-questions there. The 18 indicators, are any of them gender specific? There was menstruation, but that's not really what I mean by gender specific. Related to, it would be great to get a little more insights about the program. There was a lot of behaviors and programs that it seemed to require a household member to maybe perform behaviors like hand washing, things related to sanitation, food hygiene. Who is specifically targeted in the household? Is it specifically women? And are you assessing time use or potentially thinking about compensation of time?
Can I also collect the other question
Yeah.
before going
go
to the?
Yeah, all right. Thanks very much for the nice presentation. Very insightful. I am Kondwan from Malawi. I'm just thinking of a community where we're having different structures, maybe implementing different activities. Maybe a structure looking at WASH, another looking at agriculture issues, another looking at food security, nutrition, water supply. So I just want to learn from you, if we are using this kind of integrated approach, how did you bring together these different structures? Is it that you are creating another structure that brings together these ones? If we are doing that, how are we ensuring issues of sustainability? Because we are trying to bring something new, which is not in the community. And in most cases, if we create new structures that are not there, in most cases, if they are funded by a project, when the project phases out, those structures are also phases out. I just want to learn from that. Thank you.
More questions? Let's start with this.
No,
Because
again,
we also look at the time for the panel.
Yeah, so maybe the first part with, you asked about gender transformative and especially about the healthy village indicators. We don't have any gender specific healthy village indicators at the moment. That's again, mostly because the examples came from Bangladesh, where we are, and I'll admit this, we're a little weak on being gender transformative. So that's why we're really doubling down on it in Ethiopia. We're currently still finalizing our indicators there, and there is very, very likely to be gender transformative indicators in there, or sort of more gender specific indicators, but it's still, being sort of worked out with the government as well. And the problem with them sometimes is that it's a little harder to measure sort of quantitatively. It's a little difficult if we want to go for more qualitative measures, if we can do it on a quarterly level, if we can really compare them over time. So that's currently a debate we're having, and I think there's still a lot of room for improvement there and a lot for learning and improving as an organization as well. In terms of what we do in terms of the activities, I mean, the first thing I must say is that, you know, the implementation is really with our country teams. You know, we as the Netherlands office really try to support our countries, but don't, you know, really leave them free to implement in a way that they see fit in their own communities, because they know them much better than us. What I do know is that we have a lot of triggering tools at the moment. So that's what I'm most familiar with. So it's really about the community having discussions about, you know, sort of the wash activities, the nutrition activities in the household, like, you know, getting water and carrying water from the well to the house, you know, and sort of having a discussion around that in focus groups, saying, okay, what is done by adult women, what is done by younger girls, what is done by younger boys, and what is done by older men. And to have those discussions and really, you know, have those four groups discuss those questions separately, come together in a group and sort of trigger them in that way to really see the incredible inequalities that there often are in terms of these sort of household chores and these sort of, you know, sort of invisible labor in a way that happens a lot, that is, you know, really carried by women in the household. So I'm most familiar with those triggering tools, but otherwise, like, please connect with us later, because I'm really happy to put you in touch with our teams to have a more specific discussion on that. Who is targeted within the household? It really depends on the activity as well. You know, if we're talking about sort of more breastfeeding behavior, that's obviously much for women. If we talk about more food security issues, that's whoever's sort of doing the agriculture. And yes, we try to, you know, have equal representation for men and women, but in the end, if it's, you know, one gender more being in charge of those decisions, we sort of have to work with them, just because, again, it's about creating the impact and less about how we get there. So we try to be realistic in what we can do as an NGO. You know, we have to work within the systems that exist. And if we, you know, we cannot change everything in one day. So we try to work within existing systems with pushing, you know, forward and really going for the gender equality and being gender transformative where we can. Then the last question as well on the how do you work with the, you know, do you create new structures? We generally don't. We really try to work within existing government structures. That's, again, why our partnerships with local and regional government is really, really key. So we try as much as possible to work within those structures. Sometimes it is really necessary to set up new structures, but we really have very few of those. And I think what really does it for us in terms of how do we get this integration, it's again by being clear about the goal. If you say it's about child health and what can you contribute as a WASH expert, as a food and nutrition expert, as a gender expert, what can you bring to the table, you know, to improve child health and to really push child health forward in the communities where you work, where you're responsible for as a, you know, as a government employee or as a government worker. That is just incredibly effective. And I think that is really the true power of the Healthy Village approach. I think is really that it's, you know, putting the impact first and everything else flows from having the impact on child health. And that is what we really see with the government workers as well, who are incredibly excited about it. And again, it's mostly stories I hear from my Bangladeshi colleagues, but how happy government workers are to say, like, finally, we're doing something that's not just, you know, going through the procedures or sort of doing our day-to-day work, but really having a goal that we're clearly working towards as a community, and to work with, you know, the communities, and to have a sort of debate with communities, to have an interaction with the communities where it's not just about, you know, how are we going to implement this and this procedure, or how are we going to do these manuals? It's about how can we improve child health? And you can really have an open discussion, you know, where just that you have sort of these credentials and are a government worker doesn't make you any different than anyone in the community. And I think that is really, really powerful in the approach in the end.
Okay, thank you, Remco.
Thank you.
Yes, I want to go to the next phase. Yes, I'm sorry. We also have a panel discussion, and I would like to have that, also have some time for that. So if you have questions, please go afterwards to Remco. I would like to invite the panelists to come forward. So Julia Rosenboom, Emma Wende, and Jamie. So please come forward to continue the conversation. Yes. So Emma is the monitoring and evaluation WASH officer for the National Ministry of Kenya. And together with UNICEF, they implemented the SANNUT project, which was also mentioned by Jamie. And Julia, she's the senior change specialist at FHI 360. And Julia plays a leadership role in the Global Hand Washing Partnership and the Clean Fat Nutrition Coalition. So I'm very happy to have you here. So welcome. And we'll hope to have also time for you to ask some questions. So Emma, yes, Jamie already said something about the SENNOT project. Can you explain a little bit more about that and also compare it with the learnings you heard from the frontier study and the Bangladesh example?
Hi everyone, good afternoon. So oh, sorry. Yeah, is it better now? Is it okay now? Oh, okay. Yeah, oh, okay, better now. Yes, so as Jimmy mentioned earlier, so in Kenya, we implemented, or we are implementing what we call the SANAT. So it's more of an integrated nutrition sensitive together with sanitation. So here, mostly we focus on nutrition messages into sanitation. So what we have done is that we have modified the community-led total sanitation approach to a more modified one, including nutrition messages for nutrition. Basically, when you talk about community-led social sanitation, we have the 4 critical stages. We have the pre-triggering, triggering, claim, verification, and certification. But then with the modified approach where we are incorporating the nutrition messages, is that in between the triggering session and before we get to the claim, we have 2 caregiver meetings where we have a caregiver meeting on toddler hygiene and another caregiver meeting on toddler nutrition. So here we incorporate messages towards nutrition. And looking at the indicators that we have the 4 standard sanitation indicators for the CLTS approach, but then we've added 4 additional indicators now that look at nutrition and look at the SANAT approach. So here we are talking about child disposal, disposal of child excreta. We are talking about the courtyard maintenance or the courtyard cleanliness. We are also looking at now hand washing practices at critical stages. And when it comes now to nutrition, we are looking at complementary feeding and also exclusive breastfeeding of the kids of the under 5. So when it comes to our end and maybe the similarities that I've been able to see between what the previous presenters have done or have said is that it is more context specific to our country. And also looking at now the other similarities is that we've been able now to focus on improving child health. So as I mentioned before, looking at caregiver sanitation and nutrition knowledge and behaviors, and also just looking basically at how we can integrate the two so that we can have at least reduction when it comes to undernutrition. But looking at now my previous presenters and what they've mentioned is that we have some differences, and I think the differences are more compared now to the similarities that we're having. And in that, the previous presenter mentioned about the healthy village approach, where at the end of the day, we have a healthy village. In our case, the end approach is always open defecation free status. So these messages are being just ride on along now the journey towards open defecation free. The other bit that we look at is that when we are talking about, I saw previously the presenter was talking about the pre and postnatal care and also menstrual hygiene management. But in our case, menstrual hygiene management, we've not really focused onto it because we find that it doesn't really bring results when it comes to child malnutrition or undernutrition in child. So for that, we've actually deviated away from it. But from the findings that we were able now to have from the pilot study is that we've modified now for potential scale up. We've identified some gaps that we were able to see during the pilot study. And one of them is on monitoring. During the first phase of the pilot study is that we realized the monitoring was not effectively done. The monitoring was more geared towards the open defecation free journey. But now we're incorporating aspects to do with child nutrition and also talking about, as Alison mentioned, food hygiene and also WASH in the different components, the healthcare facilities and also WASH in schools. And the other bit is that we're also focusing on WASH in the young children. So as the National Ministry of Health, we've actually improved on our monitoring system where we are now including all the approaches when it comes to the indicators that we're talking about. Again, the other similar, back to the, just trying to get it clear, I had it here, just give me a minute. Yes, maybe when it comes to sustainability, because this one was cross-cutting across all the scenarios, is that to ensure sustainability on our case is that we are riding on other sanitation-related activities, and this, as I mentioned earlier, is on CLTS. This includes a workforce that is already in place, looking at now our community health volunteers coming from the bottom going to the top approach. So we are trying to incorporate the workforce that is there so that we can ensure that there's sustainability post the donor support that we have. The other bit is that we are also looking at a stronger focus on government engagement, as Remco has mentioned. And from the study is that it informed on our systems. As I mentioned, we are now upgrading our monitoring information system. And now we are also doing the same program, the SunNat program into another county. So based on the learnings and experiences that we received from the previous study, from the previous implementation, we are now bringing it to another county. So as Remco mentioned, for his case is more of cross-country. So for our case is more cross-county. So the different regionals that we have there. And also it has led to our revision of the protocol, which is most important in our case. As I mentioned previously, we had the CLTS protocol, but now we are going to have a sanitation and hygiene protocol, which will now encompass hygiene into all the components, and also now encompassing animal management, as Alison mentioned earlier, and also incorporating things to do with child excreta disposal, proper disposal of child excreta. Thank you.
Thank you, Emma. This is very interesting to hear and to see that there's a lot of similarities looking at the different programs, but also differences, because that's needed, because every country, every area has their own specifics. Julia, question for you. You have an enormous experience on baby wash, and what would be your top 2 recommendation to practitioners to incorporate those elements in programming?
The top 2 really stumps me, and I think there have been 2 phrases resonating here, our leitmotifs, if you will, of sort of embrace the complexity and the expand what's in the envelope. And I would just underscore those as, if you will, of my sort of two recommendations or takeaways. As far as embrace the complexity, focusing on baby wash, we really have learned, and many of the researchers and practitioners are sitting here in the room. I mean, I've worked with many of you for maybe a decade, many years, but there is no single fix to baby wash here. And that it's only if we change as practitioners and researchers, we change our focus to embrace that complexity, are we going to crack this nut at all? Because we're looking, we've looked at playpens. You were asking me in the pre-talks about some of the playpen studies, and we look at infant feces management. We looked at no one of these things. And that's saying if we even add them to comprehensive wash, no one of these things is going to do the trick. So embracing that complexity, certainly, and working system wide at the same time, when often the unit is the household that we work with. So it's again changing our programmatic and donor skills to be able to focus on households and then go back out to system wide approaches. I think another key takeaway, and I'm just peppering more than giving a sort of a comprehensive thing here, but that as we think through improving practices is what we're talking about, that we need to improve practices to see that sort of reductions in stunting and to see the outcomes we're looking for. We have to consider enabling technologies, and that did come up here. Remco, you mentioned one of the factors most was related, having a hand washing station. It was sort of one of the elements, but that yes, there's big hardware, but just the little stuff in the house, and that's absolutely essential. And figuring out how to do that in a sustainable way, again, is a whole nother, a whole nother meeting in itself, and a whole nother challenge of the decade, because we're not giving this stuff away. So it's figuring out what's a sustainable market approach for mostly rural poor and also urban households to be able to bring those things into their house. So, but the focus on enabling technologies along with the behavioral focus. And then while my offerings here are a bit of apples and oranges, but the focus on animals, again, absolutely key. And it's been absent. I think it's more prevalent now. A few of us were noting that at this meeting this year, we seem to have taken a dip again, not focusing as much. For the past 2 years, there was quite a focus. And I think, again, some of the folks here have done remarkable work on it. but that need to focus on animals. And when you start focusing on animals in a programmatic way, it means bringing in the ag sector. And that's a whole nother beast, if you'll excuse me. And it's key, but that's where a lot of the gender dynamics really play in. And we haven't even started to address that. But for the most part, these ag workers are men and they're not focused on child health. And it's not to say they don't care. Many of them are fathers and uncles and sons, but it's not the outcomes they're looking for, and it's not how their success is rewarded. And it's not, so we're asking them to come into our room, if you will, but we need to sort of head out into their room more and figure out, how do you find compatible, whether it's building 1 or 2 child indicators into their success, however it all works, but there's tremendous gender implications when you start dealing with animals in households. I could go on, as you know, I'm passionate about all this, but I'll stop for those key takeaways. And I hope, again, we have a few moments at the end to get more from you all.
Yeah,
Thanks.
so also thank you, Julia. That's very, very useful, and also nice to have that summary what you came up with. Jamie, looking at the research, and we also had that question. There's a knowledge gap. So where would you say, what kind of research would be needed to get more insight on what works well and what doesn't work well?
Okay, I'll be quick because I already presented on kind of hub priorities regarding research. And it would be good to get some other people's insights into this. But just to add to in terms of research needs, what Julie was saying about embracing the complexity and expanding the envelope, I'd also want to add kind of ensuring we're contextualizing the programs. And the comment earlier about the system or systems, if we're adding additional systems in here with regards to food systems or sanitation systems or health systems. So we need to kind of have research tools, I suppose, and methods which are rapid and don't take 5 years for us to identify what to do. So where my interests lie and where I think we would be really useful is to kind of develop and have rapid tools which can get us to understand the system and kind of what drivers and enablers at a household, community and district level, so we can really design contextualized programs rapidly.
Thank you. Very useful. So I want to open up the floor also to some questions for the team, and Remco is also available if there are any more questions. We'll start with you. I'm sorry.
Thank you. My name is Kitka. I'm with UNICEF in Ethiopia, and great to hear about the baby wash piece of work. And this is something that we did and the publication that was mentioned. But I think what is still a debate within the team is this issue of the pastoral and agro-pastoral communities. Okay, keeping of animals is part and parcel of their livelihoods. If you look at the home state and the way the animals are kept, the play environment for children, they are all together. So how can we, in reality, sort of bring a divide between a clean environment for the child, especially a toddler that is all over the place on the ground, and separating it from that potential risk of contamination is still a debate. We've tried to say, how can we, put up the indicators to measure how that is impacting on the health, but I think it's a challenge that we still find. It would be great to hear some more insights, because again, it is linked to even access to the latrine and the use of those toilets. The fact that in those arid areas where most of the pastoralists are, access to water also is a challenge. So whilst those could be things that we work on and try to get over with, but certainly the area of the issues of separating the play environment and the risks of contamination is something that is still ripe for us. Thank you.
Julia, can you maybe respond to this question? Yeah.
very quickly, and again, there's others in this room that can also address them. I do know the Ethiopia situation quite well. I'm not sure, we to try and address this, we did a small study looking at the feasibility of playpens, introducing some kind of playpen into rural Ethiopian households. The challenge of separating children and infants in this context is immense. And as you said, we did some real qualitative work too. Parents, it's a good thing for your children and animals to mingle, because their job very early on is going to be to care for those animals. And you need to really be able to sense, they want them to be brothers with the cows, because they're going to be spending their days taking care of them. And you're nodding, and I know you the scenario, at least in Amhara that I know best, you clean your house by putting animal manure over the dust. It packs it down, it keeps it fresh. Manure is fresh. And so again, we need to really understand and then co-design the possible solutions based on that thinking, not on our sort of public health models, but all you're talking about. These are people's lives and livelihoods and joy and culture. It goes back for generations, even centuries, what people do. So it's us again, wrapping our solutions, co-designing with them to figure out what's possible. Some of the specific playpens, mothers and caretakers loved them. They had tons of benefits, even beyond health. For the mothers, I was surprised how much mothers could articulate. They're tired. They loved getting the kids off their back. They felt safer. They could relax. They had time. There were tons of benefits for mothers' mental health as well as child health. They used them 2 hours a day. So we know so little about thresholds too. Does that help a child to be off that floor for 2 hours when they're back in the mess for the other, 8 or 18 hours they're awake? So I'm not giving you an answer. I'm really endorsing the complexity, but I think just a reminder, because everyone in the room knows, but we have to design those solutions with the household in mind. And I'll get back to enabling technologies. It is going to involve some simple, affordable technologies to help, I think, with those separations. There's so much more, but thank you. Yeah, thank you.
My name is Whitney Fry. I'm with Iris Group. My question is for Emma. You made a comment in your presentation about discontinuing the connection or delinking menstrual health with your work with early childhood development and childhood health. I'm curious if that was due to some research that you all had internally, or if because of a gap in the evidence or a gap in the research around menstrual health and early childhood development.
Yeah, okay. For menstrual hygiene management, at that particular time, it was not part of our focus due to lack of now maybe evidence in terms of now linking it towards stunting and also undernutrition. So the focus was more on now the nutrition messages that we were supposed now to incorporate into the CLTS programming. But then towards the end, and also the discussions that we've been having at the national level and also the subnational levels, is that menstrual hygiene management is key. So it's not that we are now linking it with child nutrition, but now we're incorporating it wholesomely in terms of now the whole bigger menstrual hygiene management. So the focus also will now be into the households and also into the schools. So trying to just bring everything, integrating all the components of health together and not just being specific to any component. And also for hand hygiene is that looking at the CLTS approach and also looking at how sanitation was being invested then, it was that hand hygiene did not really have that mention that is very appropriate, or the impact of it. But then it has come to the point of we cannot leave hand hygiene alone. We need to incorporate it from the word go and not introducing it at a later stage of time that, there is hand hygiene that we need to incorporate. So it goes hand in hand from the word go. So that is now also our focus. Also menstrual hygiene management, it was just coming in at a later time that we need to also incorporate it. But from how the government is overseeing and seeing things, how they're supposed to come out, is that we need to include all this. And as I talked about the protocol that we are having, the new protocol is that we're introducing it on the first stage. So aside from the open defecation where most of our communities in the country are, is that for you to get to the grade 1, which now is more of of where we are supposed to be open defecation free. It will include now the child excreta management, and also incorporating hand hygiene and also menstrual hygiene management. So everything under one roof somehow. Yeah.
Yes, so I think we need to end up because it's already time. And I want to thank everybody who was participating here. I think there is a huge knowledge on research, and there are a lot of examples on WASH and nutrition interventions for child health development. But there's also a lot of things that we still need to learn. So I hope we gave you some insights, and I would like to thank the panel and the presenters for being here, and if there are any questions, we're happy to support. Thank you.